Who are joining. Recording is now in progress, so there's a few people still joining, but I will start now as it is 1 o'clock. So good afternoon, everybody. My name is Justin Valentine. I'm a barrister at St John's Chambers in Bristol, and I'm going to talk about material contribution and consent in clinical negligence. Where are we now? Let me just go to the first screen. So just an admission that originally I sort of envisaged this talk as being about 50-50 consent and 50-50 and 50% material contribution, but Holmes and Poeton has somewhat changed that and has required me to do a quite significant rewrite of the material contribution part. So the consent part is actually going to take less than the material contribution part, because the material contribution is just so complex, but we'll get on to that. And I've tried to make it as simple as I can. Previously, it was essentially based on the CNZ case, which was pretty clear for clinical negligence practitioners and quite helpful. But Holmes and Poeton has rather changed that. But let's start with the more straightforward aspect, which is consent in clinical negligence. So the Bolam test, as we all know, he is not guilty of negligence if he has acted in accordance with a practice accepted as proper by a responsible body of medical men skilled in that particular art. It's expressed in the negative, which always means that experts get it slightly wrong because they want to express it in the positive. They have to obviously address the particular issue of whether the medical practitioner's practice would be practiced or would not be practiced by a reasonable body of medical practitioners, which is a bit of a mouthful, but that's what the test is, as we know. And although it's a question for the trial judge, the court will defer to the opinion of an expert on the basis that non-professionals are not equipped to evaluate specialist areas requiring a degree of skill and knowledge. Or as I sometimes say to experts in con, we slavishly follow what they say, subject, of course, to coherence, consistency, logical rationale. So let's look at Montgomery, which a lot of people will know. It's a shoulder dystocia and a cerebral palsy case. If you were to mention shoulder dystocia, that's where the anterior top hip gets stuck behind the mum's pelvic bone, which can cause hypoxia. If you were to mention shoulder dystocia to every diabetic patient, if you were to mention to any mother who faces labour that there is a very small risk of the baby dying in labour, then everyone would ask for a caesarean section, and it's not in the maternal interest for women to have caesarean sections. Well, that's a sort of patrician view, which is obviously outmoded, and the House of Lords recognised that it's not for the doctor to say it's not in the maternal interest for women to have caesarean sections. There are good reasons, as it happens, not to have caesarean sections. It very slightly increases the risk of miscarriage and stillbirth and subsequent pregnancies. But for most women in this day and age who aren't intending on having about 7 children, it's perfectly logical for them to want to have a caesarean section. The guidance is quite clear that it's the woman's right to choose that. So the Montgomery key test for consent, which people will be familiar with: an adult person of sound mind is entitled to decide which, if any, of the available forms of treatment to undergo, and her consent must be obtained before that treatment takes place. The doctor is under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternative or variant treatments. The test of materiality is whether, in the circumstances of the particular case, a reasonable person in the patient's position would be likely to attach significance to the risk. I've put that matter in bold. The patient is aware of any material risk involved in any recommended treatment and of any reasonable alternative variant treatments, because that has some relevance for the case of McCulloch, which is obviously the most recent one on consent. So dialogue was emphasised. The doctor's advisory role involves dialogue, the aim of which is to ensure that the patient understands the seriousness of her condition and the anticipated benefits and risks of the proposed treatment and any reasonable alternatives. Again, that reasonable alternatives, so that she is then in a position to make an informed decision. This role will only be performed effectively if the information provided is comprehensible. And expert input into the consent process, it was crystal clear from Montgomery that the test for what alternative treatments there are and their risks and benefits must be established by medical evidence, albeit that the test of whether the individual patient should be informed of the risk, whether it is material in the circumstances, is thereafter a matter for the court. And if it were otherwise, a patient may unreasonably assert that she should be told of a treatment which the doctor considers not reasonable. And how, after all, is a court to ascertain what the reasonable treatment options are, except by reference to the expert evidence? That was clarified in Deuce, where Hamlin LJ set out a two-stage test. What risks associated with an operation were or should have been known to the medical professional in question. That is a matter falling within the expertise of medical professions. And whether the patient should have been told about such risks by reference to whether they were material, that's a matter for the court to be determined, not therefore subject to the Boland test. So in McCulloch, the claimant had been admitted to hospital on 2 occasions with chest pains and was seen by the same doctor who did not prescribe non-steroidal anti-inflammatory drugs, ibuprofen, or discuss them because she didn't judge it appropriate to do so as the patient was not in pain. After the second discharge, the patient, who it turned out had pericarditis, inflammation of the heart muscles, had a heart attack and died. The Lord Ordinary, a bit like a High Court judge, it was a Scottish case, dismissed the claim on the basis that NSAIDs were not a reasonable alternative treatment in the circumstances and therefore did not have to be disclosed to the patient. It was held that Montgomery did not impose an obligation to disclose and discuss alternatives which the doctor did not consider to be reasonable. In the Inner House, Court of Appeal, if you will, they agreed that Montgomery had no application since this required disclosure of reasonable alternative treatments, not those that weren't indicated. The Inner House did not deal with causation since the issue didn't arise, given its conclusion that there was no breach, but did note that it could see no basis upon which the pursuers could have succeeded, since the reason for prescribing NSAIDs was pain relief, and they wouldn't have had any effect on the progression of the condition. In the Supreme Court, the claimant argued that the doctor was required to disclose all reasonable alternative treatments, and the test was to be determined by the court, not the doctor. The GMC and BMA intervened, and the Supreme Court held that the Boland test applies, and when a doctor decides that only some of the possible treatment options are reasonable, and that view is supported by a responsible body of medical opinion, the doctor is not negligent. And the court held it's important to stress it's not being suggested that the doctor can simply inform the patient about the treatment option or options that the doctor himself or herself prefers. Rather, the doctor's duty of care in line with Montgomery is to inform the patient of all reasonable treatment options applying the professional practice test. Mr. Weir, counsel for the claimant appellant, submitted that the approach of the lower courts, which the Supreme Court favoured, undermines the force of the focus on the patient's right to choose accepted in Montgomery. We reject that. The approach we favour is an application, not a rejection of what was said in Montgomery, and our approach in no sense diminishes the force of the doctor's duty of care to inform, which was authoritatively recognised for the first time in that case. And further, there was a responsible alternative in Montgomery, namely a caesarean section. There was no responsible body of medical opinion denying that a caesarean section was a reasonable alternative procedure to the vaginal delivery. In essence, I somewhat struggle as to why McCulloch was deemed important to go to the Supreme Court, because I cannot say, and I noticed that Rob Weir has written an article in the Journal of Personal Injury Law, sort of complaining about the result, which I've read. But I cannot see, it only came out a couple of days ago, I read it yesterday, but I cannot see that anything he says, alters this. And for what it's worth, I agree with the Supreme Court. This was established in Montgomery, and I don't think there's anything new in McCulloch. I have been told by some people that defendants are relying on it more. in terms of the treatment options, but I think they probably could have done that anyway. And if anything, it just focuses the mind on what the reasonable treatment options are and what the basis of identifying those are. But it was always clear from Montgomery that that had to be expert-led. Just another case here, because it happens to be a recent one, Poeton University Hospitals, which is a case on causation. The claimant underwent surgery to remove and replace a metal knee prosthesis. Often with these surgeries, like hip surgery, it can be a one-stage or a two-stage surgery. The two-stage surgery is the removal, and then they replace at a subsequent surgery. So in this particular case, the claimant underwent surgery to remove and replace, so it's a one-stage process. She contracted an infection and required an above-knee leg amputation. She claimed she would not adequately consented on the basis that she should have had a first-stage procedure, i.e. removal of implant only, which she would have preferred, and then obviously reinsertion of a metal knee prosthesis on a later occasion. Breach was made out, and that was important as the first-stage procedure afforded the claimant a greater chance of eradicating the infection. However, the claimant failed on causation, since she gave evidence that generally she followed the surgeon's advice, and his advice would have been to go ahead with a removal or replacement. So that's obviously something to be alert to in all consent cases, even if consent had been given properly. What in fact would the claimant have chosen? And if in fact the procedure was the one that most surgeons would recommend, then it's going to be an uphill battle to persuade the court that the claimant would have chosen something other. I've got a couple of case studies here. These are cases that I've been dealing with, just to sort of illustrate the way that I've been using consent on a sort of day-to-day basis. The claimant, who's about 6 now, was mum's second born. Mum didn't speak English, which, as any clinical negligence practitioner will know, is often a hallmark or is associated with clinical negligence. During her first birth, mum sustained a 3C perineal tear. That's the most extensive type of third-degree tear involving both the external and internal anal sphincters. There's a significant risk of difficulty controlling bowel movements in the future, though in fact she had made a good recovery from that, the first birth. So in relation to her second birth, there was poorly documented, it was poorly documented that the previous tear, and there was no evidence of proper consent. The mum was adamant she would have had a C-section, and to be fair, why would mum roll the dice again? And that's exactly what I put in the particulars of claim. And I think most mums would probably agree that having suffered a 3C perineal tear, if you're having your second birth, then you would opt for a C-section. So it's a relatively easy hill to climb there, causation-wise. As it happened, she didn't have a tear, but there was shoulder dystocia and subsequent brachial plexus injury. Breach in relation to failure to consent was admitted. Causation was denied in that they said, well, no, she would have chosen to have vaginal delivery in any event. There were further arguments as to the management of the shoulder dystocia itself, application of the McRoberts maneuver and all of that. And the claimant suffered permanent injury to the anterior arm. Interestingly, the defendant also raised scope of duty arguments per Khan and Meadows. That's the haemophilia testing case where the child was tested for haemophilia. They got that wrong, but in fact the child was autistic, and the Court of Appeal said, well, that wasn't within the scope of duty. On the basis that the duty could assault related to the risk of a further tear, not of shoulder dystocia. However, that largely depends on how you put the question as to scope of duty. If the duty is to use reasonable care in delivering the baby safely, not to injure the mother, then it is within the scope. In any event, in this particular case, the baby was a big baby, greater than 4 kilograms. Greater than 4.5 says you really should have a C-section. Greater than 4 kilograms says you should talk to mum about it. The baby was bigger than 4 kilograms, or expected to be bigger than 4 kilograms, and was, which should have triggered the more extensive consenting process. Now, that claim is settled on a 90-10 basis on liability, subject to court approval, which is imminent. It's only on liability because we can't deal with quantum until the child has reached skeletal maturity. but on liability, it's 90-10. And then another one, claim brought by a widow. The deceased had a fractured ankle and he was put in plaster. He was, 40s, 50s. He's just slipped on ice. He died of a pulmonary embolism while still in plaster. He had complained of excruciating pain on a number of occasions, and his wife had noted he'd gone a funny colour and all the rest of it. The claim was brought on the basis that he was not warned verbally or in writing of the risk of venous thrombosis or pulmonary embolism. This is something that happens, unfortunately, sadly, quite a lot for people who are immobile. And the NICE guideline is crystal clear that as part of the discharge plan, give patients and their family members or carers, as appropriate, verbal and written information on the signs and symptoms of deep vein thrombosis and pulmonary embolism. You don't have to be, overweight or anything, any of the other risk factors, smoking, alcohol, that sort of thing, just given to everybody. The defendant had local guidance to the like effect. And it's similar to the case of Spencer in Hillingdon Hospital, which was also a DVT case, although not fatal, which the judge held. I asked myself the question, would the ordinary sensible patient expect to have been given the information contended for? Put it another way, I asked myself, would such a patient feel justifiably aggrieved not to have been given on discharge the information contended if appraised of the significance of such information? And I consider that on the evidence before me, the answer to both questions should be in the affirmative. So this case is just a question of fact. Was not told the risk? He clearly should have been. So moving on to material contribution, which, as I said at the outset, perhaps before everybody had joined, I've had to rewrite this very extensively subsequent to Holmes and Poeton. I originally intended that this would be, essentially following CNZ and nicely balanced with the consent side of this talk and relatively straightforward and user-friendly. Holmes and Poeton has rather derailed that intention, unfortunately. And it is an area which causes confusion, particularly in relation to whether material contribution applies to divisible injury or indivisible injury or both, and as to the issue of apportionment or not. And I was thinking of an appropriate analogy for material contribution, and it occurred to me that it could be a building which had been created over many decades, created by many different architects in many different styles, without any particular coherence and at severe risk of falling down. And following that analogy further, the ramshackle building would have attracted the attention of building surveyors, who in the material contribution case are legal academic commentators, who would have noted the lack of integrity of the building and warned it was at risk of collapse. And then a new set of builders or architects have come in, namely the Court of Appeal in Holmes and Poeton, and attempt to rebuild it, whilst attempting to keep as much as possible of the old property intact and paying due regard to the various incongruent elements. And that's material contribution. It is, to be frank, an absolute mess, and Holmes and Poeton certainly emphasises that. We know that it requires multiple causes or potential causes of injury, negligent and non-negligent potentially. It's particularly relevant in disease cases, and also in clinical negligence, where there are almost inevitably multiple potential causes. For example, the disease process itself is one of the causes. So the recent Court of Appeal case, Holmes and Poeton, has provided some clarity. The Court of Appeal noting that it is an area of the law that has been bedeviled by apparent inconsistency and imprecision at the highest level on multiple occasions. I agree with that, except for the use of the word apparent inconsistency, because it's just horribly and hugely inconsistent. And as will become clear, Holmes and Poeton is, I think, probably a staging post before we get a further case, clarifying some aspects which hopefully I'll highlight. So apologies in advance for the complexity of what is about to follow. I will do my best in trying to make it straightforward and to highlight the key elements that we should be looking at as practitioners, and the areas where we need to be somewhat cautious. And there's always a question, of course, as to what extent, like with the building analogy, we have to sort of undertake an archaeology of all of the previous cases. because Holmes and Poeton does that. And, you know, Boddington castings is thrown about, and McGee in all sorts of cases. And I mean, unless you're incredibly familiar with all of those cases, the discussions become quite complex. Okay, so just to revisit the but-for test, which everybody is familiar with, would the damage of which the claimant complains have occurred but for the negligence of the defendant? You know, in a road traffic accident, it's straightforward, of course, but for the accident, I wouldn't have broken my leg, you know, or an employer's liability, you know, but for this truck driving into me, or, you know, this saw not being protected, I wouldn't have cut my arm. It's very straightforward. So in the clinical negligence context, the case of Barnett and Chelsea is often cited. Claimant's husband was sent home from a hospital casualty department after complaining of acute stomach pains and sickness. He died later that same day of what proved to be arsenic poisoning. Obviously, it wasn't a very happy workplace, to say the least. The hospital admitted negligence in failing to treat the man promptly. His widow's claim under the Fatal Accidents Act nonetheless failed because of evidence that even had he been treated promptly, he would still have died. So there was no causal link between the defendant's negligence and the patient's death. So that's a good test when there's only one cause. Its application becomes more difficult where there are multiple causes or potential causes. So let's look at divisible versus indivisible injuries, because that's an important concept to get clear in your mind to follow the various arguments. So per Holmes and Poeton, it's a characteristic of divisible diseases that once initiated, their severity will be influenced by the total amount of the agent that has caused the disease. By contrast, once an indivisible disease is contracted, its severity will not be influenced by the total amount of the agent that caused it. The classic distinction in asbestos-related diseases is between asbestosis and mesothelioma, which is a form of cancer. So mesothelioma is an indivisible disease because although the risk of developing it increases in proportion to the quantity of asbestos dust, once you've got it, it's not aggravated by further exposure. And asbestosis is a divisible disease because all of the victims' exposure to asbestos will contribute to the severity of his eventual disease. So looking at some examples, profound hypoxic ischemia, the cessation of blood flow from the placenta to the fetus, causing a lack of oxygen to the fetal brain. The longer this goes on, the worse the injury. This was the injury in CNZ, and it is divisible. Obviously, if you're without, the fetus is without oxygen for 10 minutes, you know, will probably survive that. If it's without 15 minutes, you get brain injury. If it's without 20 minutes, you get even worse brain injury. So that is divisible. Malaria, not an injury we come across very often or a condition, but it was an example given in Sienkiewicz, results from a single mosquito bite. The risk obviously increases the more times you're bitten, but you only need to be bitten by one infected mosquito, and then you've got it. So that's an example given in Sienkiewicz and of an indivisible injury. To put it another way, it is a trigger disease. So it depends obviously on how you get these conditions or what the case is about. So cancer was treated as a trigger disease in AB against the MOD, and that dealt with the former UK servicemen's contracting of cancer following atmospheric tests of nuclear bombs back in the 50s and 60s. So cancer is an indivisible injury in that context, but not normally in clinical negligence. So once you've got the cancer, because of the exposure, it's indivisible. Now, Holmes says AB was wrongly decided insofar as it said that material contribution only applies to divisible injuries. So delay in diagnosis of cancer, that's divisible in clinical negligence, since the longer the treatment delay, the worse the cancer. And as we know, there's often a question as to the extent of metastasization, whether the cancer becomes incurable. And experts have to deal with precisely those questions. But it's clearly divisible because the longer the delay, the worse the final outcome. It does get more complex there in some of the cases. So sepsis, In Williams and Bermuda, which was a Privy Council case, the claimant contracted sepsis and there was a culpable delay of at least 140 minutes before a necessary operation was performed. Sepsis develops incrementally. However, according to Holmes and Poeton, the resulting injury to the claimant's heart and lungs was treated as an indivisible injury. With greatest respect, I think that simply isn't sustainable as an argument, but there we go. Holmes says paragraph 47 of Williams was wrong, treating material contribution as an application of the eggshell skull principle. They said basically it's liable to cause confusion. So I'll come back to that sepsis example, because it seems to me common sense that if the longer the sepsis goes on, the worse the likely injury is going to be and the damage to other organs. But they treated the injury to the claimant's heart and lungs as an indivisible injury. So this is where it comes down to terminology. We will come back to that. But I think in terms of divisibility and indivisible, it's relatively clear. Query how often in clinical negligence we actually come across an indivisible injury. Most injuries are divisible. So Holmes and Poeton. The Court of Appeal has emphatically decided that material contribution applies to indivisible injuries. They referred to the analysis of Professor James Stapleton, and this is like the building surveyors in my example, the legal academic commentators picking apart judgments and saying that the courts have got it wrong. And they noted the approval of that analysis in another case. So this was the examples that she came up with. Well, in fact, some of them, if you read her article, they come from German cases, Canadian cases, and all sorts of things. So a hypothetical case adapted from an example given by Professor Stapleton, 20 individuals who all combined to push a bus over a cliff. Assume it's shown that only, say, 13 or 14 people would have been needed to bring about that result. It could not then be said that the participation of any given individual was either necessary or sufficient to cause the destruction of the bus. Yet it seems appropriate to describe each person's involvement as a cause of the loss. Treating the but-for test as a minimum threshold, which must always be crossed if X is to be regarded as a cause of Y, would again lead to the absurd conclusion that no one's actions cause the bus to be destroyed. Now that clearly follows. And then other examples include a case where the directors of a company unanimously vote to put on the market a dangerous product which causes injury, although the decision only required the approval of a majority. Again, it cannot be said that any individual director's vote was either necessary or sufficient to cause the product to be marketed. And yet it's reasonable to regard each vote as causative rather than to say none of the votes. And then there's a pollution example there. So following her analysis, which has received court approval, material contribution would apply to all of these people, even though it wouldn't have actually meant that the bus wouldn't have fallen over the cliff, even had they not done the pushing themselves, but they materially contributed. So that's sort of step one in this analysis, and it's letting go psychologically and intellectually of the but-for test. So following that analysis, material contribution is a concept wider than the but-for test. It is not appropriate in such cases to talk about the but-for test. And if you are interested, you can read Professor Stapleton's one of her articles, Unnecessary Causes. It's on Westlaw. In Holmes and Poeton, they refer to a 2023 article. It's not on Westlaw. I dare say with a bit of tracking down, you can get hold of it. But that, if you're interested in this area, reading Unnecessary Causes is quite helpful to understand what the court's going on about in Holmes and Poeton. And in my analogy, she is essentially the surveyor coming along and saying, "Oh, look what you've done to this awful building. This is never going to stand up. You really do need to get some clarity in this." And Holmes and Poeton, I would suggest, is the first step in that stage, trying to introduce some logical coherence and consistency and integrity to it, to the concept. So the question rather is that of damages, not material contribution. If there are and this is important, if there are multiple causes and the innocent causes would be sufficient to cause injury themselves, like in the bus example, a claimant would be overcompensated if they received all the damages. And she calls that oversubscription. So like in the bus example, you wouldn't succeed by saying that the 7 people, who you've identified as negligent, pushing the bus over, because the bus would have still gone over. So yes, they made a material contribution, but theoretically you should receive no damages because the bus would have still gone over. And we're all familiar with that, of course. We would call that a failure of but for, so to speak, because it wouldn't have made any difference. But she says it's not a sufficient way of analysing it. You have to think about the material contribution and then look at the damages. Professor Stapleton calls this oversubscription and gives an example of 2 doses of a drug, one innocent, the other given in breach of duty. If even the innocent drug would result in death, say because of some allergic reaction, then although the drug given negligently also caused death, a claimant should recover nothing, which follows logically. You can't overcompensate a claimant if in fact the drug hadn't been given, the negligently one, but the patient would still have died. And she says that Lord Phillips was wrong in Sienkiewicz on this basis, and she also implies that Bailey was wrongly decided. And she says that the courts have not adequately resolved this issue, and she's clearly correct. Notwithstanding the above, Holmes was moderately clear, per Lord Justice Underhill, that in the case of an indivisible injury, a tortfeasor who makes a material contribution to the injury is liable for the whole. So how do you get away from the fact that there might be a material contribution, but even absent that material contribution, the claimant would have suffered the same injury? Well, the answer to that is they haven't decided yet. Stuart Smith, Lord Justice, held no question of apportioning liability arises in this case, since no causative contribution has been shown. We don't need to worry about the facts of Holmes and Poeton, but it was a toxic chemical case where causation wasn't actually shown to have caused the Parkinson's, which the claimant complained of. Breach was made out. He shouldn't have been exposed to that level of drug, but the association with Parkinson's was very thin. So they've said they dodged it. So for similar reasons, although the prospect was raised by the court during the hearing, this is not a case which involves oversubscribed causes. These important and difficult questions should therefore be left alone until a case in which they actually arise. This suggests that there may be an erosion of 100% recoverability in indivisible injury cases. Holmes does not, therefore, answer all the questions, and as I said before, it's merely a staging post to greater conceptual and legal clarity. So let's look at divisible injuries post-Holmes. Holmes and Poeton is a disease personal injury case. At paragraph 32, the court referred to the approach to be taken when faced with divisible diseases. They referred to Mustell J's judgment in Thompson and Smith Ship Repairers, which is an industrial deafness case. I see no reason why the present impossibility of making a precise apportionment of impairment and disability in terms of time should in justice lead to the result that the defendants are judged liable to pay in full when it is known that only part of the damage was their fault. What justice demands, to my mind, is that the court should make the best estimate which it can in the light of the evidence, making the fullest allowances in favour of the plaintiffs for the uncertainties known to be involved in any apportionment. So that's an uncontroversial statement, and it's what we do all the time, i.e., what would the outcome have been absent the negligence? The damages reflect the difference between that outcome and the current situation. So in a delay in cancer case, you don't assume that the claimant had never contracted cancer. You look at the situation, had she been treated seriously, and she recovers the difference between the two, the negligent outcome and the non-negligent outcome. So yeah, delay in diagnosis of cancer provides a common example. Analysis as to what the outcome would have been absent the negligence with the defendant liable for the additional injury. The implication in Holmes and Poeton is that material contribution does not apply to divisible injuries. So I put a sort of optional analysis here, and is when I mentioned before that in some senses Holmes and Poeton engaged in an archaeology of what had gone on in all of the previous cases and how we got to the position now, which is in some senses, obviously they considered it a necessary task, but it does increase the complexity. So according to Holmes, Bonington, Castings and Wardlaw should be treated as a case about indivisible injury, even though the injury is in fact divisible. And cases which suggest otherwise, like A, B, and C and Z, adopt incorrect reasoning. You can see why I quibbled with the apparent inconsistencies observation. Per Holmes, McGee and NCB should be interpreted as an application of the Fairchild exception, though it was nearly 30 years before Fairchild. They use the slightly ridiculous expression of avant la lettre, which I had to Google, just means before the letter. And is accordingly irrelevant to discussions of material contribution. I always think it's a bad sign if you have to Google from another language an expression used in a case attempted to assist all of us in practice, but maybe that's just me. Wiltshire and Essex, the claimant was a premature baby who received an excessive concentration of oxygen. It is known that this can cause damage to the retina leading to blindness. However, there are a number of other conditions which can cause such damage. I listed them there, all of which the claimant suffered. The House of Lords reversed the Court of Appeal decision. What is required is evidence not of increased risk of injury, but evidence of contribution to injury. So in that sense, it was the same as Holmes. The judge had failed to make relevant findings of fact as to whether excess oxygen caused or materially contributed to the claimant's condition. There can be no presumption that the tortious cord made a material contribution, as in Holmes. It didn't lose, it was sent back for retrial. It wasn't dismissed, and Wiltshire is still good law. Perhaps importantly, the analysis in Davis and Frimley and Thorley and Sandwell, although neither of them were referred to in Holmes, is incorrect in relation to material contribution not applying to indivisible injuries. In fact, they reversed the situation. They said it only applies to indivisible injuries. So let's look at the issue of apportionment. In cases of indivisible injury, claimants should recover all of the damages at the moment. In relation to divisible injuries, CNZ is interesting. At para 367 of CNZ, Richie J noted that the apportionment of damages can be achieved where injury is divisible, as in Thompson and Smith, a deafness case. He therefore held, in my judgment, these authorities would support a ruling in the present case that a fair way to apportion the damages in a brain damage case caused by acute profound hypoxic ischemia at birth would be by way of a percentage based on the relative durations of the PHI caused by the breach compared to the PHI which had been suffered in any event. That's uncontroversial, it seems to me. However, after a lengthy review of further cases, and the judgment is 107 pages long, he held at para 391, in law, I consider that the cases I have reviewed above show that if there is a scientific gap making proof of causation of functional outcome, therefore also quantification impossible, in contradistinction to merely difficult, then the claimant will recover 100% of the damage she has suffered. So long as the claimant can prove that the breach made a material contribution to the reduced functional outcome, which was more than de minimis. In the event, in fact, he held that had the 6.5 minutes of negligent delay not happened, the claimant would have avoided all brain injury. So strictly speaking, his comments on not apportioning are obiter. As noted, Holmes and Poeton implies that in divisible injuries, material contribution does not apply. Rather, a claimant should recover that part of the loss caused by the tort. However, as in C and Z, such apportionment may be impossible. So this is, I'm trying to make sense of this here. It's evident that the expression material contribution is being used in two senses. One in relation to causative contribution to indivisible injuries, which was the focus in Holmes. The second, as in C and Z, in relation to divisible injuries, but where no identification of the quantifiable part of injury, what Ritchie calls functional injury, is possible. Clearly, if, for example, only a fifth of the damage occurred through the tort, then there would be no recourse to material contribution arguments, and you just get a fifth of the damages as fully assessed. So going back to Williams and Bermuda, which was this sepsis case, where there was then a heart attack and damage to the heart, the injury to the patient's heart and lungs was treated by the Privy Council as indivisible, according to Holmes. However, the injury was caused by sepsis, which is a process. Should Williams be interpreted as a divisible injury, albeit that the outcome, functional outcome, was indivisible? And obviously, my answer to that question is yes. There seems in general to be a lack of attention to process rather than outcome. Death is an outcome and is obviously indivisible, but death certificates rightly identify multiple causes, many of which may be divisible. Sepsis, for example, or the whole range of causes. So the analysis in Holmes, I would suggest, is perhaps too closely aligned to disease cases where processes may take years, rather than clinical negligence, where multiple processes may be at play over minutes or hours. And the reason for that, of course, is if you look at industrial deafness case, it goes on for 10 years, and you say, well, 5 years of it is negligent, then it's pretty easy, or relatively easy to say, well, I'm taking half of the deafness, so to speak. If half of it was negligent and half of it wasn't negligent, it's more difficult in clinical negligence, where you've got a lot of different processes taking place very swiftly. It's useful to have a look at the case of John in central Manchester, which is a well-known case and a case often cited by claimants. Dr. John suffered a head injury in a fall. There was negligent delay in arranging a CT scan, during which time he was suffering intracranial pressure causing brain damage. There was no discussion as to whether this was a divisible or an indivisible injury. So a lot of these cases do have to be retrospectively analysed and put into the sort of right framework after the event. Rather, Mr. Justice Pickin covered all bases with what seems, subsequent to Holmes, a somewhat broad brush approach. This brings me then to Mr. Kennedy's submission, counsel for the defendant, that in a case such as the present, the court should engage in an apportionment exercise of the sort carried out in the Holtby case. That's an industrial disease case. I cannot accept that this can be right. First, I'm in some doubt how this argument can work in circumstances where, as Mr. Kennedy accepted during closing submissions, if the material contribution test has been satisfied, then caution is made out. Well, that sort of lacks clarity as to what it is that they're talking about. It seems to me that if that is the position, then if the evidence is such that it is not possible to attribute particular damage to a specific cause, the claimant must be entitled to recover in respect of the entirety of his or her loss. Secondly, and in any event, I am quite clear that apportionment is not appropriate, where it is not merely difficult, but is impossible to allot particular loss to a particular cause. Common sense would suggest that brain injury resultant upon raised intracranial pressure would be divisible. Perhaps, therefore, the case would now be more accurately interpreted as a case on indivisibility of functional outcome. And it does not appear that John was an oversubscription case, i.e. it's not as if he would have suffered the same brain injury had there not been a delay in arranging the CT scan. It was certainly acknowledged that he would have suffered some brain injury, and it would have been, it was worse because of the delay. So my suggestion is that it may very well survive further development of the law subject to reinterpretation. So I've just got a case study here, the case I'm dealing with, and apologies to the solicitor involved, who I think may be watching. In a cord requirement case I'm currently dealing with, breach is admitted in relation to failure by various GPs to refer the claimant to the hospital. Further factual causation is admitted, and that absent breach, the claimant would have undergone surgery before going into urinary retention, which indicates her mobility would likely also be preserved. However, the defendant alleges non-negligent post-operative hematoma, which caused most of her injury. That's disputed. But let's say that the defendant was right about that. The defendant's negligence has caused a material contribution to injury, but of what type? If this was simply delay in surgery, then it may be appropriate to treat as a dose-related divisible injury. The longer the compression of the cord requirement, the greater the injury. So that's plainly divisible. But in the particular circumstances of this, they're alleging post-operative hematoma. So the potential causes, tortious and non-tortious, the hematoma, both could cause similar injury, like the pushing of a bus over the cliff example. It should probably be treated as indivisible, because they could both cause the same injury. There is the compression before the delay in surgery, and then there's also a non-negligent compression afterwards caused by hematoma. And it's impossible to distinguish the two in terms of the final outcome, but it's not one process, it's two separate assaults on the claimant. So my suggestion is that it should probably be treated as indivisible, so the claimant recovers 100% of the damages. But even if it is treated as a dose injury, where the longevity of compression increases the damage, can the damages be apportioned? That would require proof of causation of functional outcome, and as per Ritchie and C and Z, is likely impossible. So a few practical points just to finish with. There is probably a need early in the case to decide whether this is a case to which material contribution may apply. Is the injury, or rather the process of injury, so we don't make the same mistake as in Williams and Bermuda, divisible or indivisible? Experts will need to address that as a specific issue. If it is indivisible, the letter of claim and pleadings should allege the same, along with a claim for 100% of the damages. The but-for test becomes irrelevant, though caution should be exercised in relation to oversubscription cases, i.e. where the non-negligent causes would be sufficient to cause the indivisible injury. Which will, I mean, if I was acting for a defendant in that case, I would simply run the argument and say that nothing should be recovered. But, you know, and if it was on the balance, I think that would be probably go in the claimant's favour. But if it's clear cut that the non-negligent causes would be sufficient to cause the indivisible injury, then I think the courts would be attracted to that position. If in fact the process of injury is divisible, the more common situation in clinical negligence, there should be an analysis of whether the functional outcome is divisible or indivisible. And again, the relevant expert should be asked to address it. And if it's divisible, the relevant damages should be claimed. And if indivisible, 100% of the damages. And it would probably be sensible to record both in pre-action correspondence and in pleadings that depending on the development either of expert evidence or as to the law, the parties' cases to material contribution may have to be reviewed. Now that's just realistic because of the way the law is developing in this particular area. I mean, it's a good question as to whether tactically you might want to characterize the injury as divisible or indivisible. Because if you characterize it as indivisible, but you're in an oversubscription case, then you might end up with nothing. In reality, I think most injuries in clinical negligence are divisible. So you're probably going to be more attracted to look at it as if it is a functional outcome, which is indivisible, because then you can still fall back on the divisibility of your damages if your experts are prepared to make that sort of assessment. Okay, so just a final comment. That's our chambers, obviously. The clinical negligence is there. Rodri Jones, one of our members, has just produced a book, in fact, on material contribution. I said I'd give it a call out. I haven't read it personally, but I did have a chat with him yesterday, and his observations and thoughts about the matter I found extremely helpful. And I can be emailed there. And that is it. So I don't know whether there are any questions. I've got one here. in elective ophthalmic surgery, do you think the court would consider that material risk should include the worst? Well, that question asks about risk. Oh, this is a consent question, not a material contribution. Well, I think the answer to that question in the elective ophthalmic surgery will look at the individual patient, because I think what a lot of experts say is, you know, if you've got a really articulate, involved client who wants to know everything, then you tell them everything. If you've got someone who just says, I don't really want to know what you're doing, doctor, just crack on with it, please. I trust you. Then you don't go into all of those risks. But those are a matter for the court to adjudicate upon. So you can clearly, depending on your client, make a case there if you think evidentially that is going to fly. So that's a question of assessment of fact. I hope that answers that question. Are there any other questions? None at all? I'm going to give it one more minute and then I shall just, if you do need to answer anything on material contribution, then obviously just email me, sorry. All right, well, in the absence of any other questions, I think thank you very much for attending and I hope you found it interesting. Bye-bye.